We understand that this has been a difficult time for everyone, but we also know that many of you are trying every day to manage pain and all the difficulties that are linked to that pain. So we would like to introduce you to Dr. Dominic Aldington, who's kindly offered to share some top tips. Dominic is a member of the British Pain Society and the International Association for the Study of Pain. He's a veteran himself, having served in the Royal Army Medical Corps for more than 2 decades. He was a subject matter expert in pain to the Surgeon General, which saw him working at the Defence Medical Rehabilitation Centre at Headley Court and the Royal Centre for Defence Medicine in Birmingham. I really hope that you find his points helpful.
Well, hello everyone. Assuming there's someone listening to this, I've been asked to talk about pain for a few minutes for your course. I'm not entirely sure what's wanted, so I've put together a few bits which may or may not be of interest. If it's of no value whatsoever, let us know and I'll change it for another course. So as I say, the aim is to talk about things to do with pain. I'm actually going to start talking about me briefly so you understand why I'm sitting here and the relevance, and then we'll do the pain bit. So as far as I go, there are probably 2 bits of relevance. First of all, I'm a consultant anaesthetist by training, but in fact I only do pain medicine now. I work in Winchester in the NHS, and I've published a few papers here and there and some articles and presented around the world on things to do with pain. Perhaps slightly more relevant is I'm also a veteran. If we rewind the clock far enough, I did 4 years as a youth in the cadets at school, where I got to be pretty good with the number 4 303 rifle and all right with the Bren gun. I then spent 6 years with the Honourable Artillery Company in London doing nothing medical at all, but had to learn new weapon systems. So that was things called the SMG and the SLR. And just as I was leaving, we were introduced to the SA-80. I enjoyed my AFV recognition. The Morse code I found quite interesting. I wasn't quite so keen on walking with weight, but I managed it. And I loathed the digging. And we used to dig some big holes here and there. And then on leaving the Honourable Artillery Company, I spent 24 years as a doctor in the Royal Army Medical Corps as a regular, again, new weapon system. So it was the Browning 9mm, and I got to be relatively competent with that, and the SIG just as I was leaving. I deployed a few times as an anaesthetist, and I started the pain clinic at Headley Court. So that's why I'm sitting here. Right, pain, 10 things I think you should know about pain. Number 1, nothing about pain is easy. If you ask 6 people, you're going to get 7 replies. Number 2, in the words of my old boss, Professor Henry McQuay in Oxford, pain is common, but it is not sexy. So about 20% of us, so 1 in 5 of us, have a long-term pain. And yet, we, the medical profession, often get less training in pain than a vet. So if you don't think you're getting very far, don't be surprised. Number 3, really important, this one. Pain is always real. Pain has both an emotional and a physical component to it, always. If it didn't have an emotional component, it wouldn't be unpleasant. So some people talk about physical pain, psychological pain, things like that. It doesn't make any sense to me. Pain always has both physical and emotional. However, the longer you have a pain, the more important that emotional component becomes. But it doesn't make it any less real. Pain is always real. Pain is also an individual thing. You cannot guess my pain any more than I can guess yours. But the great thing is I don't have to guess how bad your pain is, because you can tell me. Now, I know lots of people then say, well, what's a 3 for me might be a 7 for someone else. But that's a statement that gets us nowhere. It's absolutely bone. It's pointless. If you say your pain is 7 out of 10, then it is 7 out of 10. Because I'm helping you, not the bloke next to you. Next problem. Not all pains have an obvious cause, nor a cure. Sometimes people have a pain and we don't really understand why. There are all sorts of theories, and I can bore you with theories as long as you want, but there are theories. The important question, I think, is what does the pain mean to you? And the point is, the less a pain means to you, the less of a problem it is, and thus the less painful it is. Next, 6. Own your pain. Your pain is your problem and you need to take responsibility for it. Medically, we're quite adept at taking away that from you. And it's very appealing for people to give us their problems. But conditions like pain, these long-term conditions, are not helped if you're expecting someone else to manage it for you. You need to deal with it. Only you understand how it affects you, your life, your families, your friends. You have to become the expert in your pain. And if you find you're not getting what you want, ask the question why. Are you either asking the wrong people or are you asking for something that does not exist? And I'm sorry to say that often the cure does not exist, in which case we then have to help you manage it and deal with it and cope with it. Number 7, before talking to a healthcare professional, I suggest you write down your aims for the meeting and questions you have. If answers are given you don't understand, get them to be explained. The answer could be, I'm sorry, we don't know. Well, you might not be happy with that, but it's a fairly unambiguous answer. Similarly, if you want an operation, talk to a surgeon. If you want to talk about coping and dealing and managing your pain, I suggest you go to a pain clinic. If your doctor says no, ask why. When you go for an appointment, take someone with you, a friend or a family member if you can, and always, always, always take your notebook. First, it's going to have the questions you wanted to ask, and secondly, you can write the answers in it. The other point is, if we, the doctors, see you writing the answers, we're going to think, oh, this chap's, or chapess, is paying attention to what I'm saying. So suddenly you become much more involved in the discussion. You should also get copies of letters written about you, although I tend to write my letters to the patients and send copies to everyone else. However it happens, get the letters and keep them. You need to own it. Next point, 8, Mars bars. Now, the younger ones amongst you might not know what I'm talking about, but you can go and Google it. I'm talking now about medication for long-term pain. I could talk for hours on this, and I have done, but it's not the place. The bottom line is, most of our medication for long-term pain is pretty useless. So if you find your medication doesn't help you to work, rest, or play, like a Mars bar, there's absolutely no point taking it. Much of the misery of pain is from what it stops you doing. So if your medication doesn't help you do more, if it's not performance enhancing, don't take it. Scans. Scans never, ever, ever show pain, whether it's an MRI scan, a CT scan, an X-ray, whatever you have. They don't show pain. They show many things, but they do not show pain. Some people can have dreadful looking scans and no pain, and some people can have dreadful pain and a normal scan. The point is, it's the pain that is real, and that's what we're treating. So we need to treat the man, not the scan, the pain, not the picture. But many doctors and healthcare professionals like to fall back and look at the pictures and focus on that rather than focusing on you. Finally, whatever happens, please try to be polite and courteous. You should be firm, but always polite. None of us get out of bed with the intention of ruining your day. So if things aren't going your way, stay calm, work out what's going wrong, and fix it politely. That's all I've got to say. So I hope the course goes well, and I hope this was of some passing value. Thank you.